you so much, ma'am, for the kind introduction. And first of all, thank you, Day, for this lovely opportunity to speak on such an important topic. And thank you, Saima, for setting the ball rolling so beautifully. Uh, I'll pick up from where ma'am said that, everybody cannot do CGMS, and neither should we think that CGMS is here to replace SMBG. Nothing can replace SMBG. SMBG is something that we need to empower our patients with. And of course, yes, then we also need to leverage all the tools that are available. So without further ado, allow me to share my screen and I will be up and running with my session. Thank you so very much, Cheryl, specifically for giving me this opportunity of speaking on CGMS. So basically, talking about CGMS, right after SMBG. So just taking you back in terms of how the diabetes has evolved. Over the period of years, we've seen that diabetes has, first it was discovered, then we identified through the urine that it is diabetes, how the story evolved, how, sugar started getting tested in urine with various chemistries, how they discovered the islet cells of pancreas, and so on and so forth. Similarly, there's also been an evolution in glucose monitoring, and how monitoring of glucose was done using urine strips first, followed by dextrostick strips testing blood glucose, then the first glucometer ever, which is the AMES, that was discovered, and then there was A1C that came in and changed the whole platform, and now we have the CGM sensor that we're talking about. CGMS, if we look at it, it seems as if very new, but it's a story that has been going on for quite some time. So the first ever CGMS was all talked about or brought about in 1999. Yes, 1999, you heard me right. So which means that it's not something that we've been doing today, but it's been there for quite some time for it to be coming to us today. But obviously, we have much refined process today as compared to earlier. As we know, everything evolves, so has the monitoring and the devices for monitoring as well. So if you look at it, this is just a timeline that I've put together to show that, how the different discoveries had happened. And majorly, if you look at the one below, where there's the AMES reflectance meter, then there's the biostator, which was, doing the CGM ever in 1979, you can see a little glucose kinetics was studied. And similarly, you can see the various glucometers and the pumps as well coming up in near time. So talk diabetes management, which is obviously the essence of, the entire effort, mammoth effort that Cheryl and the team Day have been taking, is that there is diet, there is medicines, there is exercise, and there is monitoring. These are the four fundamental pillars of diabetes management. So obviously we talk about medicines, we talk about exercise and diet, but we must ensure that patients have been doing their monitoring as well, without which it's very difficult for us to know how they are doing. Journey that has come from the self-monitoring to continuous glucose monitoring. Obviously, we do have these, long-term studies that are available that said that if you look at frequent testers, on the left-hand side, so it shows that in traditional blood glucose testing, many a times there is hypos and hypers that may get missed, because at that point in time, the patient may not be aware that he is having symptoms, or may not be able to realize those symptoms, or may not be able or accessible to the monitor, and thereby may miss those readings. Whereas if you look at continuous glucose monitoring, because this captures 24/7, therefore, even while the patient is sleeping, you do not miss any single reading over this particular tool. So this continuous glucose data can actually be seen as capturing those missing readings that may have been missed on traditional monitoring. First comes A1C. When A1C came in, I'm sure you all know that people started saying, oh, just forget the fasting and post lunch, do the A1C. That is giving us much more information. Yes, it definitely did a little more than what the fasting and postprandial stand for. But at the same time, we must question everything that we hear. Does A1C really tell us the whole story? Well, sometimes no, because the same HbA1c, you can see here A, B, C, D. All these patients on the left-hand side have the same A1C of 7.1, but they have different glycemic profiles that have been captured using continuous glucose monitor. So, which means that with the same A1C, patients may actually be going a topsy turvy glucose journey through the day, but you may not be able to pick it up just via the blood glucose readings or via the A1C. But of course, like I said, nothing replaces the other. The utility of A1C can be enhanced when you look at the glucose monitoring data through the CGM. So you can see on the right hand side, where again, 2A1C is 7.7%, but you can actually make out which one is going through what. Of course, we know that glucose matrix have been evolving. Everything is evolving, and of course, there is going to be one benefit of the other. And therefore, you see, if we have to move beyond A1C, there is lack of reliability of A1C alone, and it needs SMBG also, because SMBG will give you a little more picture of the specific day, but SMBG again will have limitations by itself. So if you add A1C and SMBG and then utilize it along with the CGM, I think that is what the message I would like to give in today's talk eventually. Then come on to what is a CGM? We've been talking about CGM. What is a continuous glucose monitor? So basically, it is nothing but a small device, a 2 rupee coin kind of a device, the Abbott device that I'm talking about, which you can actually apply to the back of your hand laterally, upper arm, which once applied tracks your glucose 24/7 in the interstitial fluid. So, mind you, sometimes it may be a slip of tongue that you may be talking to the patients and you tell them that it checks your blood glucose, but no, it checks your interstitial fluid glucose. So ISF glucose is what is picked up by the CGM device through the sensor. Okay, and there is a reader which you can use to scan the sensor, which then transmits the reports to you. And usually these readings are picked up every 5 minutes, and therefore you get around 1,000 to 1,500 readings within the 14 days period that this sensor is applied over the hand. Now, how does CGM measure? So it's a very unique technology. It has a very sterile, thin, flexible fiber, which you can see in the diagram below. It is inserted just below the skin to be subcutaneous to reach the interstitial fluid. And that's where it stays. And therefore, whenever we apply the sensor, we ensure that we guide the patients that they do avoid friction at the area where the sensor is applied. At times, people may ask you, oh, is it going to interfere with my daily routine? So, no, it does not interfere with the daily routine. You can actually even bathe with the sensor. People can swim with it up to 3 feet with this particular sensor as well. But important to note, yes, sometimes people forget and thereby they may happen to rub the sensor with their towels, and that's what we need to tell them to avoid. So this enzyme technology, which is not dependent on oxygen to provide glucose readings, the sensor operates at a very low electrical potential. And therefore, when you're applying the sensor also, it's just like a minor mosquito bite and not very inconvenient to the patient or a lot of discomfort to the patient. Just want to show you what exactly this report tells you. So this is the standard ambulatory glucose profile that comes up with the CGM. Now, the area under the dark blue curve, which just showed up in orange, is nothing but the glucose exposure, which means how much glucose exposure is the person having in 24 hours. Then, if you look at these orange arrows that we have put up in 4 different arenas, these are basically talking about the variability in the patient, okay, which is telling you how the patient is varying through the day and whether it is ideal or not ideal. Then you can accordingly devise your treatment in the patient. You have this light gray area, which is nothing but the again showing you the variation, but this reflects more of the lifestyle. So now the dark blue area which you have seen plus the gray area which you have seen, these are the interquartile and interdecile areas, and the dark blue central line is the line that represents the median, and that tells you that 50% of the readings lie on this particular median. This ball rolling, this basically tells you the stability of glucose in the patient, which means how stable is the glucose during the day. Of course, you will see in any patient, there will be variations. After meal, there'll always be a spike. But how regular is the spike, how differential it is what the AGP tells you. And this particular AGP or the graph is actually a representation of 14 days of how the patient's glucose has traversed. Then, of course, if you look at these shaded areas, the ones above 200 are actually showing you hypoglycemia and risk of hypoglycemia, where the ones shaded below 70 and 50 are actually showing you the hypoglycemia or risk of hypoglycemia in these patients. So you can not pick up hypo and hyperglycemias, but you can also predict that this is where the patients are having hypoglycemia risk. And therefore, if it goes beyond this, probably you may have to increase or decrease your treatment or insulin and titrate accordingly. CGM, of course, we talk about matrix, we talk about fasting, post lunch, A1C. So, CGM also gives us a matrix, which is nothing but time in range. This time in range is the measure which we talk about today in terms of CGMS. So in 2019, the American Diabetes Association brought consensus over this particular domain, saying that if you look at time in range, there are certain targets for different populations, be it type 1, be it type 2 non pregnant, be it pregnant, and so on and so forth. And this time in range actually gives us a very good idea of how the patient's glucose status is. So, this is how they have divided. You can see that between 70 to 180, the green area is nothing but the time within range. So how much time patient will spend within this time is known as his TIR. In short, the yellow is time above range, TAR, and the pink below is nothing but time below range or TBR. So obviously, the standing target should be you increase the time that the patient is spending in target, reduce both the time above and time below spent in range. So these are the different targets as published, but I will like to show you in a graphical format. So if you look at it here, now type 1 as well as type 2, there's going to be difference, but this is how the CGM device looks on the right hand side. If you look at time in range, the ideal target is more than 70%, between 70 to 180 milligrams per DL. That comes to around more than 17 hours per day, average 16.9 hours to be precise. And if you look at time below range, it has two differentials. One, it has to be less than 4%, which is less than 70 milligrams per DL. And for critical hypoglycemia, which is less than 54, it should be spent, one person should be spending less than 1% time of the day, which is less than 14 minutes per day in this particular range. If you look at time above range, again, two differentials, again, two ways it has been characterized. Less than 25%, he should be above 180 milligrams per DL, and less than 5% of the time, he should spend more than 250 milligrams per DL. So this is again similar when we see adults who have type 1 or type 2, very clearly you have the time in range target set. You can see for older and high risk, there is a slight resting where you have the time in range which you need more than 50%, time above range goes to less than 10%, and time below range becomes more stricter because you know that this is where the casualties happens in these particular patient personal subject pool. And you have pregnancy type ones, of course, then you have, a little more stricter. You have 70%, you have less than 25%, and less than 4% again. Now, populations, of course, four phases of life, 10 to 18 years, 18 years onwards, pregnancy, elderly, all these different phases, we have seen people have been recommending, different institutions have been recommending different uses of the CGM and TIR. Of course, like I said, nothing replaces the other. So A1C is clearly linking with TIR. You can say that, for example, a patient has an A1C of 7. That means the patient is spending TIR time in range of 70%. And so on and so forth. You can take a look at the different A1Cs that has been given. This is published by Maclino et al. In 2019. And therefore, every 10% increase in time range is going to give you a 0.5% A1C reduction in 1 diabetes and 0.8% A1C reduction in both type 1 and type 2 as per two different studies. So if you want to lower the A1C, Using CGM aim to increase the time in range. It will indirectly lower down your A1C and thereby improve the glucose control. Range has also been studied on microvascular complications. It shows that every time there's a decrease in the time in range, which means more hyperglycemia, there is an increase in the retinopathy and nephropathy chances by 64 and 40% respectively. Which means if the reverse is true, if you're improving the TIR, you're actually avoiding the increase of risk in these complications, microvascular. So, microvascular also, there has been a publication which says in 2020, Velu et al. Said that time in range was looked upon, and every 10% betterment of time in range showed a 6.4% lower risk of carotid intima medial thickness being abnormal. When this carotid intima medial thickness is nothing but directly associating with the cardiovascular risk in patients. So which evidences are there? You have the impact study, there's a replace study. So both in type 1s and type 2, there's Lang et al., which has both combinations of type 1s and type 2 that talk about that how increasing time in range is going to help, how reduction in hypoglycemia in type 1s and type 2s is going to help eventually in improving the glucose control. And very important point, when you're giving the patients a tool that they are empowering themselves with, where they are able to take the reins in their hand and see their glucose and thereby be able to make changes in their lifestyle, that also helps these patients a lot and improves glucose control a lot. So it is, bringing back the state where we are saying that diabetes management is about multi assessment by a team, where you have not only the team of doctors but the patient himself also as an active part taking in his or her diabetes management. So to summarize about TIR, there are clinical benefits. You're obviously seeing the reduction in A1C. You're seeing the glycemic control indirectly getting better. There are studies that say there's ICU stay that gets reduced. There is nocturnal hypoglycemia, daytime hypoglycemia that gets significantly reduced. And overall, you see that the patient's quality of life improves multifold. And of course, various populations, you can look at it during the reduction in the poly pill, where you have a lot of pills. You want to titrate the number of pills. You want to adjust the timing of the pills. You want to titrate insulin. You want to optimize the doses. You want to look at patients with gestational diabetes. You're looking with patients. Even during pandemic, we had patients because we were not able to see the patients. So CGM really helped at that time as well, where they were able to virtually or remotely tell us how they were doing in their terms of your glucose sugars. Same ways, even for diet and lifestyle changes, you can ask the patients to utilize this tool as well. So why CGM? To end my session, I would like to say that technology definitely adds value. We all use smartphones today to the best of our needs, and therefore we should ensure that if we can use this for our patients and leverage it to the maximum, that's best. This sensor comes as a 3-in-1 solution, where you have it using as a CGM, you can use it as a blood glucose. It also has facility for checking blood ketone in these patients. And of course, it has proven clinical benefits. So, for me, this is a standard ending slide, and I like to show this that evolution always has a story. And I'm sure you will be imagining the man, monkey, ape story here. But this is what I like to show, that earlier we started doing finger sticks and we continue doing that alone. Then we came up to AGPs, which is the CGM, which is ambulatory glucose profile. And now we obviously are looking at the new metric, which is TIR, or time in range. There is another terminology which is coming in, which is time in tighter range, which is TITR, which tighter, and therefore more and more better control that we can aim for patients to give them better lives. So with that, I end my session. Thank you so much.